Yes.
Or might we ask for it? Give it a minute or so for it to register in the live dashboard. Live stream is still offline.
They're representing all of
Starting
Canadians.
soon.
Yeah. So,
And we're on.
the governing council, yeah.
Have to reload that.
We're in strategic planning right now, so, and also conducting a governance review for the first time in the organization.
There we go. That one? That's the one.
That's great, yeah. Well, it was really meant, I think, for Mike to be a listening tour and to
Perfect.
get to know people.
Let's pick up the microphone.
Start to build some relationships. It was lovely. It was so good.
Like I'm not concerned.
Yeah, definitely. Absolutely. People were very sweet and it was wonderful. Yeah. And then like seeing people that was like, it was wonderful. People were so kind to work.
Is it? I'll be here.
What am I mainly working
You can sit wherever you'd like. Or do you want to sit here actually? This one's better. And you're closer to the presenter, you can ask questions.
Do you guys see anything else? Yes, so maybe we should talk. Yeah, so the idea would be to use like emergency departments in a couple of provinces and to look at the acute effects of exponential interventions.
We worked together for a lot of years.
I'm trying to put together Smith scholar application around it. Yeah. I envision encouragement to write it this year, right? Like it's fun.
Yeah.
This year, but like it's helpful in any sort of it makes me think about research agendas now, which is helpful. So I would agree. So excited that that's
I'm sure you will. I only think
it just randomly contributes to collaborators here to look at Canadian data sets. To be the challenge has been like, since somebody who works in administrative data, the transition into a new country while still maintaining to the US has been like, that's the trick. Yes, yeah. Yes, I have so there's something I do at Health Canada before I click here, like every time I don't apologize data I have, but then you can get it, and it's like, okay, like, you can work together.
Thanks for coming.
And the next time it'll
I'm going to meet.
Sorry.
You can come to the after if you want. I know, I thought it would come with that. I know! It's an open invitation. We got four vendors. For the first time in our lives. Well, that's not true. I grew up with 4 vendors. I know electricity and other things. Yeah. You good? How are you? Okay.
So you're the user, you guys all are going to
She's not a master's then. Okay, you are a master's.
Oh, I'm suggesting like just doing this one. Yeah, because. And so, well, you have a house. Some experience on that. So we can do that. Start doing the. I may be using that part, and so when people ask questions, I'm so happy to see you. Oh my God.
I mean, it's a very interesting topic too.
So,
When are you coming to see? Yeah.
are they all doing the exact same? That makes it easier but boring.
I had no idea you were doing what you
I think actually,
Is this from the
so you do that.
So we have 3 people on right now.
Yes.
You just need to make sure that if the screen drops.
Actually, you just have it running your screen. So not only next week, we've also got
Yeah, we got time.
No problem. I know, I was just exactly.
Are you sticking around these parts for Christmas?
Sort of in and out. I'll drive down to Seattle for 2 nights to see my family, and I have not seen my partner's family since we moved to Canada, so I have to go to Cincinnati.
Wow.
Yeah. What about you? I know that's nice.
She can't be.
didn't see it. I think it was actually the topic. I was like,
When Peter's doing the report chart, they're on their phones.
welcome to rounds for December and I have some introductions to make and Sherry's
Quiet, please!
get people to take a seat so that we can get going. Part of the philosophy around rounds is not only are we featuring professors who, some of whom are going on to more wonderful things, but we are wanting to make sure that we've got time to discuss what they have to say afterwards. So that's why I'm being Nazi about doing this one. Okay, so I wanted to make just a couple of introductory remarks that, of course, I would like to acknowledge that we are meeting on the ancestral and unceded territory of the Musqueam people, for whom we are grateful. I would also like to remind everyone that our next round will be January 31st, also coincidental with the full faculty meeting. And that's going to be Eugenia Oviedo-Schultz, who is going to be also giving us a wonderful round. So January 31st, put that in your calendar. Today, we are having a fabulous last chance.
Huzzah!
And a chance to really celebrate a body of research that is unparalleled, is absolutely fabulous, and also the people who are carrying it forward. And so I'm going to give the introduction to everyone, and then let them do the switch when it's time for them to speak. So in addition to Jeannie, who I'm going to introduce the report in a moment, we have Kathleen Deering with us, and Andrea Krusi, and they're going to be talking about their roles in the Center for Gender and Sexual Health Equity, both of whom have fabulous backgrounds for doing this extensive research, community structural interventions and community-based research, and looking at social inequalities and marginalized and people living on the downtown east side. So it's going to be absolutely wonderful. And then, of course, I wanted to speak to Jeannie. And Jeannie, many of you know, is taking on an amazing administrative position in Halifax. She's going to be leaving us. But the work that she has done to move forward this research agenda, I would not even be able to, if I had the whole time, I would not be able to mention it all. But I think that I'm going to just summarize it by saying in 2015, she was inducted into the Canadian Academy of Health Sciences as, quote, outstanding public health scholar whose leadership and vision has contributed to system change nationally and internationally. And I can't think of a better way to introduce Jeannie. So with that, I am going to let her speak for herself. Two more things is that questions can be tweeted. We're going to have an extensive question time afterwards. So, and for those of you who are claiming CME credits, follow that link.
Thank you very much for that lovely introduction, and I really am so excited to see so many familiar faces here today, and I know that we have a number of people joining us via link online. Thank you to all of you for making time to be here today to listen to what I hope you will find to be a very inspiring presentation, and to engage with us in a conversation more broadly about important issues related to sexual health equity and marginalized communities. Before I go any further, I want to acknowledge someone in the room who has been a research partner of mine for a very long time. That is the founding executive director of the Center for Gender and Sexual Health Equity, Dr. Kate Shannon. Dr. Shannon holds the Canada Research Chair in Gender, Equity, and Sexual Health and Global Policy, and has been the driving force in gender, sexual health equity in marginalized populations, and has created Vancouver as a global reference site for this work and a globalized standard for making an impact in this area. So I'm delighted to have you here today. And I'm also very excited to have two fabulous colleagues from the Center for Gender and Sexual Health Equity to present their work, which I know will blow all of you away with regards to the kinds of activities that they're engaged in and the way that they conduct their work. It's been my honor to be the Associate Director of the Center, just as it is my honor to have worked, lived, and played for over 2 decades on the land of the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And for that, I will be eternally grateful. I also today think it's important, and I appreciate you, Karen, acknowledging this at the faculty meeting earlier, that December 6th is a significant day to mark in our calendar, particularly here in Canada. Today marks the 30th anniversary, if you will, of the massacre that occurred at l'École Polytechnique in Montreal, where 14 women were murdered and targeted by a gunman. And I just would like to ask all of us to pause, remember, memorialize their lives, as well as the lives and violent experiences of others in response to gender-based violence. So please join me in taking a moment. Thank you. So the timing, obviously, to launch a new center focused on gender and sexual health equity couldn't be better. And we are so excited to have our new center launched, housed at Providence Healthcare with faculty affiliates, staff, trainees, and a growing body of international collaborators and people from across the country engaged in our work. That really brings together and brings into focus the issues of equity, diversity, and inclusion as they pertain to sexual health. I don't have to explain the concept of equity to anyone in this room, but I did want to just take a moment for some folks who might conventionally think of sexual health as solely residing in the realm of preventing sexually transmitted infections. And I just want to, and I encourage folks to think more broadly, as we do at the Center for Gender and Sexual Health Equity, that sexual health also includes issues to do with freedom of expression and gender identity inclusion. And here I really want to cite the work around LGBTQ2S+ communities. Sexual health relies on addressing consent and freedom from sexual violence and other forms of gender-based violence. As well, positive sexual health, including comprehensive sexual education, are central to the work that we do. And finally, a reminder that sexual health and reproductive health access is an issue that pertains to all genders. And I think this is an important point to keep in mind as we go forward. The center, as I said, is a large group. There are over 70 of us currently working under the mandate of our center to advance gender and sexual health equity, with a particular emphasis on underserviced and marginalized populations in British Columbia, across Canada, and internationally. And I think today you'll get a real sense of, as I mentioned earlier, the degree to which the work that we're doing here in Vancouver and around the world is actually having global impacts. And I think when you listen to Andrea and Kathleen's presentations, you'll have a real sense for that. Our aim is really to bring together interdisciplinary faculty, students, staff, to build and implement programs of research, policy, practice, and education around promoting sexual health and gender equity for underserviced and marginalized people. Our research, as I said, is interdisciplinary. You'll hear today how much of our work is very community-based and participatory. We do work in the clinical realm. We also do research all the way through to arts-based work. And you're going to be very excited to learn more about how we engage in that work today. All of our research is focused on developing an evidence base that informs ethical and effective policy development, as well as informing and bridging that research to practice gap through accelerated training opportunities and enhanced educational opportunities for professions of all sorts. So it's with this framing that I am very excited to turn the microphone and slideshow over to Dr. Andrea Krusi. Andrea is an assistant professor in medicine and a research scientist at the Center for Gender and Sexual Health Equity, and a former postdoc at the School of Population and Public Health. Welcome.
Well, thank you so much, Jeannie, and it's an honor to be here today on this important day to be able to talk, tell you a little bit more about my research at the Center for Gender and Sexual Health Equity. So, my body of work has focused broadly on the criminalization of sexuality. The criminalization of sexuality and reproduction around the world is a major barrier to human rights and denies millions of us our human dignity. The criminalization of sexuality and reproduction refers to when consensual, sexual, and reproductive actions and decisions, or the expression of sexual or gender identity, is restricted or punished. This includes, for example, the criminalization of same-sex activity and abortion. My research thus far has focused predominantly on the criminalization of sex work and the criminalization of HIV non-disclosure. So today, I would like to highlight two case studies of my research relating to sex work policy and the criminalization of HIV non-disclosure, and also looking at the gendered effects of both of these policies, and show how, in collaboration with our amazing team at the Center for Gender and Sexual Health Equity, we have worked to mobilize this research in the policy realm as well. So, I lead an innovative, community-based, participatory, critical public health research program. My body of work is rooted in an ethno-epidemiological approach and draws on multiple research methods, including qualitative and arts-based methods, as well as ethnographic observation. My team's research has a strong policy focus, and I have recently secured funding through the Canadian Fund for Innovation to build on my work to establish an arts-based community research and knowledge translation hub in Vancouver's downtown east side. This will be instrumental in further developing participatory approaches to research as well as knowledge translation that can portray nuanced meaning in an accessible way to a broad variety of audiences, including policymakers, clinicians, marginalized communities, and the broader public as well. So, before turning to our work on sex workers' occupational health, I want to give you a little primer on sex work laws globally. So this is a map by the Global Network of Sex Worker Programs that shows the legal status of sex work globally. As you can see, the color red dominates, really highlighting that the global policy response to sex work has been focused predominantly on criminalization some or all aspects of sex work, with the notable exception of there in the corner, New Zealand and some parts of Australia where sex work has been decriminalized. Over the past decade, as you know, Canada's sex work laws have been in flux. Until December 2014, Canada, like many Commonwealth countries, didn't actually criminalize the act of buying or selling sex, but many activities around sex work, such as solicitation of sexual services, living off the avails of sex work, and keeping a bawdy house or a brothel were criminalized. In 2014, in response to a Supreme Court of Canada challenge, the previous Conservative government implemented end demand legislation, which criminalizes clients or sex buyers and third parties, as well as advertising for the sexual services of another person. This has been there's been a global trend to implement end demand legislation in many parts of the world, including in Sweden, Norway, France, and also Northern Ireland. I will now present some of our findings of how prohibitionist approaches to sex work shape the occupational health and safety of sex workers, and how we've used our research to inform policy reform. So this is a study that I led that was published in the American Journal of Public Health that evaluated a naturally occurring safer environment intervention that continues to be prohibited under end-demand legislation. This intervention was implemented in the context of supportive housing programs for marginalized women. My study evaluated how providing structural and environmental supports, such as the opportunity to call staff or rely on peer safety networks, shape sex work transactions among the most marginalized sex workers who predominantly solicit their clients in street-based settings. Ashley, a cisgender woman sex worker, summarizes how this intervention shapes her sex work transactions and highlights how the prohibition of operating a bawdy house or a brothel negatively impacts her occupational safety. So I like to do a sex work transaction on my territory. You know, you've got people around you that you can count on. You can stop when you want to. Out there, you're like a hostage almost. You feel almost that bad if you were out there. You're going to settle, you're going to put yourself in a bad position maybe. If it's not going good, you're stuck. And that's not a good feeling. You don't want to be isolated, then you might be willing to hurt yourself in order to maybe get home. You maybe have to do extra things just so that you can get home, and that's not cool. Given that this safer sex work environment intervention was implemented in a publicly funded housing programs, in a legal environment where operating a bawdy house was illegal, our knowledge translation efforts had to be well coordinated and thought through as to not cause harm and risk the closure of these programs. We received support from high-level public health officials and issued separate policy briefs to the police department, the mayor, the Minister of Housing, and the Minister of Health to give them a heads up about our findings. This work also garnered significant media attention. In addition to this qualitative analysis, our team at the Center for Gender and Sexual Health Equity, under the leadership of Dr. Shannon, has produced a significant body of evidence that documents the negative effects of criminalization and policing on sex workers' health and safety, that has been featured in over 50 articles in leading medical and social science journals such as The Lancet, BMJ, and Social Science and Medicine. We submitted the majority of this work, including the aforementioned CGSHE paper as evidence in the Supreme Court challenge regarding the constitutionality of Canada's sex work laws that reached the Supreme Court of Canada in 2013. And CGSHE, in collaboration with the Canadian HIV/AIDS Legal Network and HALCO, acted as an intervener in the case. And in December 2013, on a glorious day for sex workers' rights, the Supreme Court struck down Canada's sex work laws as unconstitutional and gave the government 1 year to implement new legislation that it was in line with the ruling. This was a great day of victory for sex workers' rights. Given the Conservative government's track record, though, there was a good chance that in reforming sex work laws, they would implement an end-demand approach, including the criminalization of sex buyers, but not sex workers. So the Vancouver Police Department in January 2013, in response to decades of inaction, in response to missing and murdered women from the downtown east side, had already implemented a similar approach, where enforcement efforts focused on sex workers' clients, but not sex workers themselves. As such, Vancouver had been an end-to-end criminalization environment since January 2013. This constituted an excellent opportunity for us to evaluate this naturally occurring experiment using a variety of data sources, including qualitative and ethnographic data, policing statistics, and violence prevalence measures from our longitudinal cohort of sex workers that evaluate sex workers' access to health and social services. This highly cited study published in BMJ Open showed for the first time globally that policing strategies that target clients reproduce the harms created by the criminalization of sex workers themselves, in particular, risk of violence and abuse. Jasmine, a cisgender woman sex worker, summed up the impact of the policies succinctly. Harassing the clients is exactly the same as harassing the women. You harass the clients and you're in the exact same spot you were before. It's exactly the same thing. Exactly. I'm staying out on the streets. I'm in jeopardy of getting raped and hurt. Together with a constitutional analysis provided by our community partners, Pivot Legal Society, as well as Sex Workers United Against Violence, we sent the findings of this work to all senators and members of the Canadian Parliament to inform them about the negative impacts of end-to-end criminalization. The findings of this study garnered significant media attention and were referred to repeatedly in the parliamentary hearings around the reform of sex work laws. Unfortunately, in December 2014, the previous Conservative government implemented end-demand legislation to regulate sex work that criminalizes clients as well as commercially profiting from sex work of another person. Over the past 5 years, we've worked to monitor the impact of this new legislation. And earlier this year, I've been able to secure a 5-year CHR grant to continue to evaluate the impact of evolving sex work laws on the occupational health and safety of sex workers. And importantly, to delineate the pathways through which law reform and renewed policy frameworks can best promote and regulate Canada's sex industry. So stay tuned. I am now going to talk about my work on the gendered impact of the criminalization of HIV non-disclosure. The criminalization of HIV non-disclosure is a prominent global health policy issue. The Global Commission on HIV and the Law, UNAIDS, the UN Rapporteur on the Right to Health, and the World Health Organization, amongst others, have raised concerns regarding the harm inherent in an unjust application of the criminal law in the context of HIV to both public health and human rights. Despite the well-established science that antiretroviral therapy dramatically reduces HIV transmission risk, a growing body of evidence pointing to the shortcomings of the criminal law in governing HIV transmission in over 72 countries globally, Canada stands out in its very assertive approach to HIV criminalization. So in Canada, a person living with HIV needs to disclose their HIV status unless a condom is used and they have a low viral load. Currently in Canada, there is no HIV-specific law. HIV is prosecuted as most commonly prosecuted as aggravated sexual assault, which makes law reform quite complicated, but it's beyond scope for today. And HIV disclosure is, like I said, most commonly prosecuted as sexual assault, and that also makes it so that people end up on the sex offender list after they've been charged. So the criminalization of HIV non-disclosure is often positioned as a way of protecting women. Yet very little empirical data documents the actual impacts of this law on women living with HIV. To change this and to set a research and policy agenda, we held a research roundtable in 2015 together with our community partners, the Canadian HIV Legal Network, and many others. And we're able to bring together academics, community members, policymakers, lawyers, and clinicians. I was able to co-chair the event together with a peer researcher, Flo Ranville, and this event really helped lay the groundwork for our subsequent research on the gendered impacts of criminalization of HIV non-disclosure. So based on the priority set at the roundtable, I led a qualitative study that highlighted that the criminalization of HIV non-disclosure renders women who are already disproportionately affected by gender-based violence, and Kathleen's going to talk more about that in a moment, at additional risk of violence from intimate partners. HIV disclosure can shift relationship power dynamics by aggravating partner abuse and manipulation. Likewise, women who experience rape or sexual assault may not report to police for fear of HIV non-disclosure charges. In recent positive developments, based on calls from the Federal Department of Justice, both BC and Ontario have implemented prosecutorial guidelines that state that people who have a low viral load for at least 6 months should be exempt from prosecution for HIV non-disclosure. While this is a step in the right direction, limiting the reach of the law, a quantitative study that I led and I presented at the 2018 AIDS conference in Amsterdam indicated that despite this reduction of the reach of the law, 48% out of 277 women living with HIV in our longitudinal study would still be at risk of criminal charges due to HIV non-disclosure. Those at highest risk for prosecution are the most marginalized women living with HIV, those who are marginally housed, sex workers, and women who've been recently incarcerated. This highlights the need for further law reform. Additionally, in response to the priorities set during the research roundtable, I secured a Vancouver Foundation grant to support participatory arts-based research on the gendered impact of HIV stigma and criminalization. This project culminated in a week-long photo exhibit in Vancouver's downtown east side, and we held an opening event where we had a diverse panel of experts, including clinicians, lawyers, women living with HIV, who spoke to their experiences with HIV criminalization and stigma. Since then, we've been able to bring parts of this exhibition to Toronto, and we were also able to present this work at the Women and Feminist Deliver conferences that were held in Vancouver earlier this year. And we co-organized a satellite event together with CanWash on this issue as well. So all of this work fed into separate policy briefs to the provincial as well as federal attorney generals, and the submission to the Parliamentary Standing Committee on Justice and Human Rights. And in June 2018, our peer researchers were able to personally present the findings of our work to the new Justice Minister, David Lametti, at the Symposium on HIV and the Law and Human Rights. So, in the same month, the House of Commons Standing Committee on Justice and Human Rights released a report that recommends HIV law reform that limits HIV prosecutions only to actual transmissions. This measure would reduce the number of HIV prosecutions in Canada, but stops short of criminalizing the intention to transmit HIV, which is what UNAIDS recommends. In the context of evolving prosecutorial approaches and federal law governing HIV non-disclosure, continued evaluation of these approaches remains imperative. Currently, there is limited understanding of how evolving approaches to the criminalization of HIV shape the experiences of women living with HIV in the context of an increased focus on viral suppression. There are also many uncertainties regarding law reform with regards to the impact of the introduction of an HIV-specific law versus the risk of the broader criminalization of other communicable diseases, and the potential for criminalization reaching beyond intent to include criminal recklessness or negligence. So, similarly, little attention has been paid how public health interventions now intersect with evolving approaches to the criminalization of HIV non-disclosure. There is a critical need to better understand this and to establish clear best practice guidelines for public health authorities in governing HIV treatment adherence and disclosure. As in the era when an undetectable viral load equals a negligible risk of HIV transmission, treatment compliance becomes increasingly central to the prevention of HIV. And this gives rise to concerns of increasing coercive public health interventions targeting treatment compliance. And we've seen this in a case most recently here in Vancouver, where in an unprecedented case, here in BC, a person living with HIV was issued a court order to comply with an HIV treatment order and was outed publicly as living with HIV through the police and later on through the media. So, to continue this work and to better understand the intersection between public health and criminalization, we need to continue this work to really understand these evolving issues, both locally here, but also globally. And to that effect, I've recently submitted a CHR grant application to further support this work, so fingers crossed. I will continue to work closely with my local and global community partners and academics and policymakers to work against the criminalization of sexuality. Thank you, and Kathleen is going to talk about her work on gender-based violence among marginalized women.
Thank you very much, Andrea, for that really important presentation. And I'm really happy to be here today at my alma mater, presenting today on some of my work at the Center for Gender and Sexual Health Equity on gender-based violence and implications for global health practice and policy. Gender-based violence substantially undermines sexual and reproductive rights globally. Issues related to gender-based violence have gained attention globally, including from the growing #MeToo movement, which has brought to focus the many and pervasive forms of sexual violence, largely in the workplace. Despite this focus, sexual violence and gender-based violence more broadly is rarely considered a public health issue. Increasing research positions gender-based violence as a global health problem and policy issue because of the pervasiveness of violence globally, as well as the serious consequences for the physical and emotional health of women, children, and those with marginalized gender and sexual identities. While in some countries there has been positive movement towards the creation of legislation surrounding gender-based violence, in some countries we're also seeing a rollback of legislation. There's evidence, some evidence, to suggest that violence is lower in countries where legislation exists, and same-sex relationships remain criminalized in many countries worldwide. Much evidence does suggest that gender-based violence is highly underreported, especially in countries where people know their reports will not be acted on, and this is also true in Canada. As mentioned, we are currently, well actually I'll bring this up as well, but we are currently in the middle of an international campaign on 16 days of activism against gender-based violence. This campaign runs from the 25th of November, which is the International Day for the Elimination of Violence Against Women, to the 10th of December, which is International Human Rights Day. And of course today, as Jeannie mentioned, is December 6th, which is the National Day of Remembrance and Action on Violence Against Women. I lead a program of research at the CGSHE on gender-based violence and how to optimize health programs and policies to address gender-based violence, including trauma and violence-informed practice and care. My work has largely focused on research with cis and trans women who experience heightened conditions of social marginalization and structural gender inequities or marginalized populations. I work on these issues in parallel, largely in Canada and India since 2004, and these programs have been very helpful to strengthen and inform each other. Work on gender-based violence has largely been conceptualized on a general population level, with a focus on intimate partner violence against cisgender women. You may have heard a commonly cited statistic of more than 1/3 of women having experienced sexual or physical violence in their lifetimes. And this is largely, again, measured as intimate partner violence against cisgender women. However, growing understanding has expanded this definition to include people of all genders and a broader definition of what constitutes violence. So gender-based violence is violence perpetuated against someone based on their gender expression, gender identity, or perceived gender. Gender-based violence involves use of power or abuse over another person or group of people. It can be any form of violence or abuse that inflicts physical, sexual, or emotional harm and social suffering, including physical, sexual, and emotional violence, but also threats and intimidation, harassment, economic violence. Gender-based violence can operate at both systemic and structural levels and does include discrimination and stigma. A disproportionate burden of gender-based violence is experienced by marginalized populations, who have largely been excluded from discussions on this at national and international levels. In Canada, in particular, gender-based violence against Indigenous people is ongoing as well as historical, and is a direct result of settler, colonialism, residential schools, and genocide. Canada's failure to act on or address decades of missing and murdered Indigenous women has been highlighted for years by individuals and communities from Indigenous communities over decades, but has also been highlighted internationally by the UN, which calls for urgent and immediate action. Of note, BC is the first province to implement UNDRIP, or the United Nations Declaration of Rights of Indigenous People, and this has just been in the last week. My work and the work of the CGSHE has largely been focused on bringing attention to the socio-ecological context that results in heightened risk for gender-based violence among marginalized populations. For example, the CGSHE was commissioned and approached by the World Health Organization Department of Reproductive Health and Research as expert contributors to a 2012 report to contextualize the effects of gender-based violence on sexual and reproductive health outcomes among marginalized populations. This work was published in conjunction with a number of international government and community organizations, including UNAIDS, UNFPA, and the Network of Sex Work Projects. It has made an important contribution to global health policy guidelines related to optimizing sexual and reproductive health among marginalized populations. As part of this work, I led a systematic review published in the World Health Organization, or published in the American Journal of Public Health with our World Health Organization colleagues on the correlates and prevalence of violence against sex workers. This work has been highly cited and drew on several studies that I led or was part of, based in India as well as Canada. Overall, the review suggested that lifetime violence against sex workers was very high. Significant heterogeneity was observed both in how violence was measured, and also we noted that higher prevalence was driven by laws and legislation surrounding sex work, which Andrea brought up in great detail in her presentation as well. Of concern but not surprise, unfortunately, I can see that there's a bit of a strange box there, but lifetime workplace violence was very high among sex workers and could be as high as 75%. And recent workplace violence was as high as 55%. Lifetime partner violence was also as high as 73% across countries and as high as 61% for recent partner violence. Our work, and my work as well, also challenges public misconceptions and policies with recommendations to increase the safety of marginalized groups. Global large-scale events have long been sensationalized in terms of the risk for increases in sex trafficking, as well as heightened vulnerability to sex workers, clients, as well as the general population. And this has been used to justify increased police crackdowns and policing, as well as more stricter legislation before and during these events, which occur ostensibly to reduce risk. I conducted this study that challenged these ideas and suggested that while there was increased police harassment in the lead up to the games, we found no evidence in increases in either the number of new sex workers to the city or reports in trafficking, either in the Olympic or post-Olympic period. We did, however, note that there was a lot of evidence to suggest that sex workers had increased difficulty meeting clients due to road closures, security, and increased policing. And as Andrea pointed out in her presentation in a number of different ways, this actually ends up increasing risk to sex workers much more strongly through sex workers being forced to make quicker decisions about clients who might insist on sex without a condom and could also commit acts of violence. I also led this editorial in the DMJ to discuss these issues in more depth, and this work has been used in the lead up of other sporting events to help shape recommendations for citywide strategies on sex work. My research has also had an impact on global health policy through my involvement since 2007 with an international team of researchers on the evaluation of the Avahan Initiative, which was a Bill and Melinda Gates funded project in southern India, and many of you have heard of this. The Avahan Initiative was a large-scale community structural intervention with major components that addressed HIV prevention and treatment, as well as aspects of community mobilization and violence and policing of sex work with marginalized populations in 4 southern states of India. While the evaluation of public health interventions with marginalized populations is challenging, given that it's often unethical to conduct randomized controlled trials, multiple forms of evaluation can be used to triangulate results. Among other studies from the larger intervention evaluation that I contributed to, my work suggested a dose-response relationship between heightened exposure to the intervention and increases in consistent condom use by clients and intimate partners of sex workers. I've continued this work in various ways, and for example, this very recent publication that uses economics methods to clarify the risk that sex workers in India are forced to take under constrained economic conditions and violence, as well as ongoing collaborations with researchers globally on comparisons of violence and policing across countries and downstream effects. Drawing on this work, I was invited to be a member of an international team that developed a study published in a high-profile Lancet series on sex work. This study used deterministic transmission mathematical models to simulate potential HIV infections averted through structural changes in regions with concentrated and generalized HIV epidemics and high HIV prevalence among sex workers. From this study, you can see this figure, which shows the percentage of HIV infections averted among sex workers and clients on the y-axis. And then on the x-axis, different combinations, singular combinations of interventions that can be enacted on the structural level. So in settings such as Canada and Kenya, where sex work is criminalized and sexual violence among sex workers is pervasive, elimination of sexual violence alone could avert between 17 to 20% of HIV infections in sex workers and clients. You can see that safer work environments also could have a substantial impact on the epidemic's course. Decriminalization of sex work could avert the largest percentage of HIV infections in sex workers and clients over the next decade through iterative effects on violence, policing, safer work environments, and HIV transmission dynamics. This study was launched at the International AIDS Conference and was highly cited. It had a substantial global impact. There were regional and international press conferences conducted across many countries. The study had 50 associated media stories across 20 countries, including coverage on the first page of the Washington Post. The study has also been used for multiple international guidelines on sexual and reproductive rights of sex workers, including Amnesty International's policy on the use of evidence-based research and support of decriminalization of sex work, as well as cited in a follow-up op-ed in the New York Times. Drawing on innovative mapping studies that I've led that highlighted the key role of neighborhood violence as a barrier to health access for marginalized women, I was also invited to contribute to international guidelines to guide prevention and treatment of HIV. I co-led the section on how to optimize care and practice for women and contributed to the section on sex workers. In this, we highlighted the importance of addressing violence and stigma as barriers to sexual and reproductive rights, alongside optimal health access for marginalized populations. From my early work on violence, sexual and reproductive rights, and health access, my research increasingly focuses on how health policies and practice can address gender-based violence. Aligned with this, I recently led a study that was guided by our Positive Women's Advisory Board as part of the 5-year CIHR study on Mission MTI. We developed a framework and a scale to measure trauma and violence-informed care to support women's health access. This study showed that women whose care had higher scores on the trauma and violence-informed scale were more likely to report better self-rated health, quality of life, reduced HIV stigma, and higher adherence to HIV medication. Other research that I lead suggests that longer distance to clinics acts through interruptions in sustained care and being on medication to affect viral load suppression for cis and trans women living with HIV. And as shown in this map, some women will travel long distances for HIV care to avoid stigma and disclosure of HIV status in Metro Vancouver. Alongside this work, the Center for Gender and Sexual Health Equity has received new funding from the Federal Department of Women and Gender Equality, and this was $1 million of funding, to evaluate trauma-informed practices for criminalized women and gender-diverse people who have experienced gender-based violence. Drawing on over a decade of research with survivors of gender-based violence, I've also recently submitted applications to CIHR as well as NIH funding schemes as PI, and these funds are intended to support continued research by survivors of gender-based violence, including for marginalized populations. The funds are intended to support the development and piloting and feasibility assessment of interventions that are trauma-informed and violence-informed to support engagement in key sexual and reproductive health services. I also aim to draw on long-standing research expertise and experience in the evaluation of naturally occurring and planned interventions at the CGSHE to evaluate global health policies surrounding legislation of violence and impacts on health, safety, and well-being of marginalized populations. So today, on December 6th, which again is the National Day of Remembrance and Action on Violence Against Women, we highlight collectively that eliminating gender-based violence on a global level is fundamental to achieving sexual health and gender equity, where all people have the capacity to live dignified lives, free from fear, stigma, discrimination, and associated health outcomes. I hope that today we've demonstrated the importance of critical public health that ensures and mobilizes results to have impacts on national and global health policy levels, and ensure and support the health, safety, and well-being of all people, including marginalized cis and trans women with HIV and other marginalized populations. So I did have a slide that showed all of our acknowledgements and partners. One more? Okay. I just wanted to end here. It's a very important slide because we really focused on our wonderful and engaged community partners, advisory boards and collaborators who have supported our research. So collectively, these partners and collaborators have made critically important contributions over many years to actively guide, shape, drive, participate in, and do this research every day. So thank you very much for your attention on this.
Why don't I have all three of you come up? We're going to take some questions now. I have to come to you with the microphone because we are taping this, if you don't speak in the microphone, we miss that part of the tape. Stefano, sir? No,
Nothing
good.
yet, not yet.
And I encourage, the first round of questions goes to graduate students. So if there are any students in the audience that have a question, you get first dibs. Okay, then I'm going to open up questions to the rest of the population. Yeah.
Thank you all very much. Very timely and educational session. I'm interested in the occupational health and safety aspects of sex workers, and they do not, to my knowledge, get counted in our WorkSafe BC. They're not covered. Can you envision ever a role where WorkSafe BC would have a role in health and safety for sex workers? I'm citing BC here, WorkSafe BC.
Well, ultimately, that would be the goal, and that would be possible when sex work becomes decriminalized. And so this has happened in New Zealand, where there is actual workplace guidelines for sex workers. So actually, currently, we have an interview series that we conducted over the last couple of years with sex workers who work in indoor environments and third parties who work as receptionists, security personnel, and just to mention here too, there's a big overlap, like in any other industry, between people who might be, move from a sex work position into more of a managerial position, or they move back and forth. And so we're just analyzing that data, about 32 qualitative interviews, and we're just working on the coding framework, and what we're going to use as the coding framework is the occupational guidelines from New Zealand to really draw out what could work. And ultimately, now would be the absolute goal, and that's the beauty of where we could get to with the decriminalization, and the difference between decriminalization and legalization, because legalization is separate and distinct from decriminalization. Decriminalization really refers to removing all the laws regarding sex work from the books and treating it just like any other profession in the service industry. And so yes, I think that would be the ultimate goal, and we would love to work with WorkSafe as we move forward.
Sure, yeah. Thanks, Mika. Yeah, and just from it's very difficult to enact these kind of policies when we don't have, when sex work is not decriminalized, right? So, as I've been saying. But just from a quantitative perspective as well, we have done some research that has created a safer work environment scale and looked at how that has increased the safety of sex workers, certainly, largely in indoor settings. But actually thinking back to some of our earlier discussions and remembering that we included the same questions on a Canadian Community Health Survey on occupational health and safety, we were able to compare that quantitatively and just highlight some of the really high levels of workplace violence that sex workers experience among other reasons. So I think that's very helpful, and going forward, yeah, definitely attention to those issues. So.
And the only thing I'll add to that is to thank Carwa for inviting a presentation from one of our trainees who did a fabulous job in highlighting both parts of this work. So thank you very much for being open, progressive, and I think really intelligent in your conceptualization of occupational health.
I don't think the mic is working, so I'll just speak loudly. So I'm curious, as you just posed the question of decriminalization, removing the laws prohibiting behavior from the books, and treating things as in your words, like any other service, right? But services are regulated by government. We don't, restaurants are subject to regulations. All kinds of service providers are subject to regulation with penalties for violations of various kinds. So what is known, or what are your thoughts, or what has been happening internationally in terms of thinking about that side of things? Because decriminalization is one thing, but that doesn't mean just anything goes, right? So.
Absolutely, and I think that's why Mika's question is so important, to really be able to establish workplace regulation. So we've seen that in New Zealand, where sex work has been decriminalized for some years now, where sex workers themselves were very involved in helping to actually build those regulations, because sex workers themselves are the expert on how to best run different sex work environments. And it's also really important to keep in mind that there's no one sex work environment. The sex industry is a very diverse place with very different workspaces that require different regulation. Where it's important is really that sex workers are involved in building those regulations. And so in New Zealand, this has given rise most recently, where a sex worker was able to bring forward through an employment tribunal a case of sexual harassment in the workplace. And she was actually then awarded a compensation for her, for enduring the harm through the sexual exploitation from a manager. And also the manager was then ordered to go through gender sensitivity training, right? So we can bring really the industry out of the shadows and work together with sex workers who are the experts in really regulating it in a way that works, so that then there is more workplace safety for sex workers, and that can actually be kind of monitored, and there's a clear standard for it.
I think go ahead. We apparently don't have the other mic. Go for it.
Okay. So with the resurgence of in the media recently with the VPD officer who, the abuse of power, where he was the sex crimes officer, I'm wondering whether any of your research can be translated. Like, would the decriminalization of sex work and the solicitation of sex work reduce the abuse of power by those in authorities, or can that be translated at all?
I think it's complicated, right? Like, to really change the workplace culture or the police culture, I think it takes more than the decriminalization of sex work. I think the decriminalization of sex work is really important also to kind of be really clear. It's not a panacea. There still needs to be workplace regulation, and there's still going to be a misuse of power at different levels, as long as, like, sort of the broader societal structures that are based on, like, patriarchy or oppression of people, of racialized people, of indigenous people, and so on. That will still be in place, right? So I think in terms of your question, I do think that decriminalization would help bring into light some of these abuses, and therefore would contribute to ameliorating them. However, I think we still, as a society, have a long way to go to really change, like, the structures more broadly, the institutional structures of the police, of other governmental and other institutions, to really work towards ending the exploitation of marginalized people.
Just one comment to add to that, and I thank you, Andrea, for that comprehensive and insightful remark. And you made me think in your response that the healthcare system is also a site of stigma, a place where people, marginalized people, are not treated appropriately. And so I think it's important to shine the light on very obvious and egregious abuses of power. But I think that even within the healthcare system itself, we need to look at the flagrant and the micro level aggressions that are launched at gender diverse populations, at indigenous populations, at marginalized communities, at sex workers. I think that, you know, we have to take a very hard look at our own house as well, in addition to the kinds of examples that you highlighted in your questions, so thank you.
Thanks to both of you. And just to build on that and say that the same structural violence that underpins gender-based violence and the same structures that result in gender inequities are the same ones that result in sex work being criminalized to begin with, and also can result in the same levels of abuses that we see. So it's really trying to attack those structures that will have significant impact.
I'm going to have to call the session to a close. I thank you so much for such a wonderful, wonderful presentation. And I do have to say, and a special thank you to Jeannie and all of this.
Thank you.